Dr. McCullough. Our next witness is Dr. Harvey Risch. Dr. Risch is a professor of epidemiology in the Department of Epidemiology at the Public Health at the Yale School of Public Health and the Yale School of Medicine. Dr. Risch received his MD from the University of California, San Diego, and his PhD in biomathematics from the University of Chicago. He's the author of more than 325 original research publications and is a member of the Connecticut Academy of Sciences and Engineering. This year, Dr. Risch researched the efficacy of 7 outpatient medications for the treatment of high-risk COVID-19 patients in 42 hospitals across Brazil. Dr. Risch.
Senators and colleagues, thank you very much for convening this hearing. We all understand the endemic disease that we are facing and that we have to face head-on and not hide from it, hoping that it will go away. And so I'm going to give you my perspective on this. In May of this year, I observed that results of studies of a drug suggested to treat COVID, hydroxychloroquine, were being misrepresented, but what I thought at the time was sloppy reporting. We've heard from Dr. McCullough how COVID disease progresses in phases, from viral replication to florid pneumonia to multi-organ attack. Viral replication is an outpatient condition, but the pneumonia that fills the lungs with immune system debris and is life-threatening is hospitalizable. We've also heard how each phase, each pathologic aspect of the disease has to have its own specific treatment, how those treatments are derived from the biologic mechanisms of the disease. Thus, I was frankly astounded that the studies of hospital treatments were being represented as applying to outpatients in violation of what I had learned in how to treat patients in medical school. We're now finally coming to address why over the last 6 months, our government research institutions have invested billions of dollars in expensive patent medications and vaccine development, but almost nothing in early outpatient treatments, the first line of response to this pandemic. And it's not that we've lacked candidate medications to study, we've had a number of promising agents. But I think that the early on conflation of hospital with outpatient disease served to imply that treatment of outpatient disease had been studied and found ineffective. This illogical premise motivated me to look at what actually the evidence for outpatient disease and its treatment were. So I want to reiterate that we are considering the evidence for early treatment of high-risk outpatients to prevent hospitalization and mortality. And that's it. I'm not talking about inpatient disease. That's a totally different consideration. I'm talking only about outpatient disease. So this is treatment starting in the first 5 days or so after the onset of symptoms. Treatment of older patients or patients with chronic conditions like diabetes or obesity, heart diseases, lung diseases, kidney diseases, immune system diseases, survivors from cancer, and so on. These are the people who are most likely to die from COVID, and they are the people most in need of protection. So in doing my research, I sought to obtain reports of every study of every medication pertaining to early treatment of high-risk outpatients. I monitor the literature daily, which is a task. And what I have found is actually remarkable. What I've observed is that while there have been positive reports of a number of drugs, every study of the outpatient use of one particular drug, hydroxychloroquine, with or without accompanying agents, has shown substantial benefit in reducing risks of hospitalization and mortality. Now, these studies break down into 2 major types. The first is the double-blinded, randomized controlled trials that various government and scientific personalities say provide the strongest, supposedly the only trustworthy form of evidence. The second is non-randomized but still controlled trials. There's some truth in that assertion about the nature of the quality of the evidence, but there's also much falsehood. We know, for example, that the great majority of drugs used to treat heart diseases were established before randomized controlled trials, with non-randomized trials. Cholesterol-lowering drugs were in widespread use before randomized trials were ever done. Azithromycin, which is the most common antibiotic used in children, was not established by randomized controlled trials. The great majority of drugs that are in use today were not established when they went into widespread use with randomized trials. Many of them had randomized trials later, but the establishment and use of drugs is not always done on the basis of randomized trials, but on the study with other kinds of studies. And thus, the idea that only randomized trials provide trustworthy evidence is a simplistic notion that sounds good in theory, and perhaps Dr. Jha later may tell you that it's what many doctors believe, but this idea does not stand up to the body of medical studies and data that addresses it. And in fact, we have large amounts of empirical data looking at the difference between non-randomized and randomized trials. Dr. Tom Frieden, who was previously the director of the Centers for Disease Control, in 2017 wrote an extensive essay in the New England Journal of Medicine showing that non-randomized trials and randomized trials provide equivalent compelling evidence, equivalent evidence for the efficacy of treatments. So could you please enter the Frieden article into the record? Underlying this was a gigantic meta-analysis of meta-analyses, what I call a mega-analysis, done by the Cochrane Library Consortium, which is a British organization formed to organize evidence-based medical research. The Cochrane investigators examined what involved tens of thousands of study comparisons. This is a gigantic amount of data between randomized trials and their corresponding non-randomized counterparts. And when they compared these two kinds of studies, they found that they arrived at virtually identical conclusions. And please enter the Engelmeyer study also into the record. This evidence is why well-performed non-randomized trials are every bit as much of a gold standard today as the randomized trials you've heard of. This is empirical data, not opinions. This is empirical data. So what did I find when I investigated hydroxychloroquine in early use among outpatients? Right. The first thing is that this drug is extremely safe, exceedingly safe. We know this from common sense. This is a medication that's been used for 65 years by hundreds of millions of people in tens of billions of doses worldwide, prescribed without routine electrocardiogram screening. It's given to adults, to children, pregnant women, nursing mothers. Such a drug must be safe, and it must be safe when used in the initial viral replication phase of this illness, which is in fact, in outpatients, initially similar to a cold or flu. And so, could you please put the Oxford, the Lane paper and its supplement into the evidence, into the record? This is a paper showing of more than 900,000 hydroxychloroquine users that showed no excess mortality and no increased cardiac arrhythmias. And also, please put into the record my article from the American Journal of Epidemiology where I discuss the Lane paper. So in spite of the safety, surprisingly, in July, the FDA posted a warning against outpatient hydroxychloroquine use on its website. And they did this while at the same time, the FDA actually had no systematic evidence of adverse events in outpatients. And the website itself says that it justifies the warning based on evidence that it had in hospital patients. It justified it for use in outpatients, which is what I said before was invalid. There are now 7 studies of early use of hydroxychloroquine in high-risk outpatients, and every one of these studies has shown significant benefit. This includes 636 outpatients in Sao Paulo, Brazil, 199 clinic patients in Marseille, France, 717 patients in a large HMO network in Brazil, 226 nursing home patients in Marseille, more than 1,200 outpatients in New Jersey, 100 long-term care institution patients in Andorra, and almost 8,000 patients across the entire country of Saudi Arabia. All of these studies showed about a 50% or greater reduction in risk of hospitalization or death. And in fact, the Saudi study was, as I said, a national study, and it demonstrated a 5-fold reduction in mortality for hydroxychloroquine plus zinc, the two of them used together, versus zinc and standard of care alone. And none of these studies have shown a single fatal cardiac arrhythmia among the thousands of patients that were treated in these studies that was attributable to hydroxychloroquine. And in fact, in addition to this, there have been 6 outpatient randomized controlled trials. We've heard a lot about this. These trials individually were small and incomplete and were stopped early, but together, when analyzed together, as we did, they show a statistically significant reduction in risk, and that's what matters. So that's the Ladapo paper, if that could be entered into the record also. So this body of evidence for hydroxychloroquine dramatically outweighs the risk-benefit ratio for remdesivir, for monoclonal antibodies, and for the difficult-to-use bamlanivimab that FDA has approved for emergency use authorizations while denying the emergency use authorization for hydroxychloroquine. This is an egregious double standard that FDA did on hydroxychloroquine that needs to be overturned immediately and its emergency use authorization application approved. I'm restating that every outpatient study of hydroxychloroquine has shown benefit. There are no studies, as far as I know of, as of last night, that are of high-risk use in outpatients that do not show benefit at all. So now we've spent the last 6 months with formal government policies and warnings against outpatient treatment. The government has invested very large amounts in vaccines and expensive new treatments, which have yet to be proven, while there's been almost no support for evaluating inexpensive but useful medications. 250,000 Americans have died from this mismanaged approach. And even if we find that the vaccines eventually work effectively and safely, as we all hope, myself included, people will still get sick and die, and early outpatient treatment is still and will be continuing an essential part of ending this pandemic. Thank you very much.
Thank you, Dr. Risch.